So, a little introduction on tonight's call. The webinar is called Winning the Battle for PCOS. And before I introduce John, I'm just going to share a little bit, like a little preface for this call. 1 in 8 women have PCOS, and it causes a lot of difficulty in terms of conceiving. And tonight we're going to be chatting about exactly what PCOS is, how it affects your fertility, lifestyle habits that you can do to overcome it, and other management options that ultimately we're really looking to give you the information to make the best decisions with your fertility. So let's start off by introducing John so you can learn a little bit more about him. Dr. John McNaught, and he likes to be called John, is the founder and medical director at Fertility Ontario, a provincial leader here in fertility care. After graduating from medicine at the University of Manitoba, John served at University Western Hospital, and after completing his residency, he returned to Western to pursue a Royal College Fellowship in Reproductive Endocrinology and Infertility. Basically, that designation is held only by a handful of physicians in Southwestern Ontario and represents the highest level of training available in reproductive care. So he's won numerous awards for his outstanding research in the treatment of infertility, and he's helped hundreds of mothers and fathers grow their family. What sets John apart as a fertility specialist is his passion for his work. He and his wife have been blessed with 2 beautiful children and know firsthand the difficulties that his generation faces when trying to build a family. John will be the first person to share with you that the most rewarding part of his job is educating and empowering people to create their own fertility and family success. So without further ado, welcome John to the call.
Okay, thanks a lot, Melissa. Thank you so much, everyone, for coming. I'm always amazed at how many people will sacrifice an hour of their time to learn something new and to try and find a way to deal with their individual diagnosis. Tonight is going to be a difficult topic because PCOS, as many of you are experiencing, is not something that is well understood. That's something that isn't well understood by patients, isn't understood by family doctors, and isn't even really understood by fertility specialists well. It's a diagnosis that we're constantly arguing about and defining and redefining, and I think at the end of the day, the most important thing is what it means to you as an individual. And the experience is so varied for each person that I don't think it's really fair to, label people as being one thing or the other. What we're going to try to do tonight is understand this process a little bit better. So, as Mel pointed out, we're going to talk about the most common hormonal abnormality that affects women of reproductive age, which has unfortunately been named Polycystic Ovarian Syndrome. As in our previous webinars, comments that are made are very general, and they may not relate to you and what you're going through. So one aspect of that is, don't take what I say to be directed at you or your individual experience, and specifically, and the lawyers make me say this, this information does not constitute specific medical advice. So what we're going to talk about is, this disease or syndrome, this label, how it came to be and how we define it today. As I mentioned earlier, it's got a huge variation in terms of its presentation. And I think if we look at a few examples of that, you'll really start to understand how, this particular syndrome is many, many different people kind of mashed into one label. And I don't think there is a sort of defining experience that every single patient can relate to. One of the things we're going to spend some time on, because it's so important, is the links between PCOS and obesity and insulin resistance. This is not something that affects all patients with PCOS, but it's very, very important. And finally, management options. We will discuss the many different treatment options available for you. And, just for starters, PCOS does not need to be a diagnosis that you cannot beat. It's a good prognosis fertility diagnosis. It is a challenge. Some people do struggle with it for several months or years, but ultimately, many people with PCOS have an excellent prognosis for building a family. Other comment I'll make is that I realize there are some people with PCOS who are not actively trying to become pregnant right now. The webinar is going to deal specifically with fertility. So what is now called PCOS was first described in 1935 by Stein and Leventhal, who were American gynecologists. And in some of my more classic patients, I will actually say, oh yeah, you have Stein-Leventhal syndrome, because when it was classically described, the symptoms were quite severe. Women would tend to be very androgenic. Most didn't get periods at all, and they had very large cysts on the ovaries. Back when Stein and Leventhal coined this particular term, ultrasound was really just a theory. So although ultrasound is a huge component of the diagnosis today, back then Stein and Leventhal were making a pathologic diagnosis, because it was not uncommon to be operating on a woman's ovaries at that time. And so they took women with these hosts of symptoms and showed that they had this change in the ovaries that they described as polycystic. And that's how this syndrome or disease came to be known as Polycystic Ovarian Syndrome, was its association with this appearance in the ovaries. And that's something that confuses a lot of patients and also doctors, because the word cyst has some very ugly connotations to it. So polycystic, that is a bad sounding word. And it's something that I really wish they would rename this syndrome, because even the term cyst is not anatomically or physiologically correct. We know now that what were previously described as cysts are actually small follicles, the precursors of mature egg-bearing sacs that are arrested in certain stages of growth. And you can see on the right-hand side here, in a normally developing ovary, there's a single dominant follicle that is much bigger than all the others. In PCOS, what you happen to get is a state where many different follicles will mature somewhat, but not differentiate to the point where there's a dominant follicle. And part of the physiology of PCOS is a buildup or an arrest of follicles within the ovary, so that over time the process becomes worse and worse. And what happens within the ovary doesn't explain the entire phenomena, but certainly, we know that much of the physiologic process of PCOS actually happens in the ovary itself and in the fluid that supports these follicles. So you may have asked yourself at one point, do I have PCOS? Because my neighbor has PCOS and I don't look anything like her. The internet tells me that PCOS women are obese, and I'm not obese. The internet tells me that all PCOS women have signs of increased testosterone, and I don't have that. I had an ultrasound done and I didn't have polycystic ovaries, so I must not have PCOS. And that's the problem with modern day diagnosis of polycystic ovarian syndrome, is that it's so inclusive in terms of the criteria for diagnosis that if you are liberal with the criteria for diagnosis, most women with any type of menstrual irregularity will be classified as PCOS. The criteria that we use to diagnosis were introduced first in 1990 and then revised in 2003. And in 2003, by what are called the Rotterdam criteria, you only need 2 out of the 3 major criteria in order to get the diagnosis. And so you can see that you can have ovulatory dysfunction, hyperandrogenism, polycystic ovaries, or 2 out of the 3, and still classify as having PCOS. when you think about, ovulatory dysfunction is really any absence or irregularity of ovulation. And amongst fertility patients, that's a tremendously common diagnosis. Similarly, polycystic ovaries on ultrasound, particularly in young women, is a very common finding. So when you take together a feature of symptoms that are common, and you only need 2 out of the 3 of them in order to meet the diagnosis, you can see how this is a label that is being applied to many, many young women. And if that helps them manage their symptoms, or if that helps them become pregnant, then classification is important. But if being labeled with PCOS doesn't help you towards your eventual goal, then there's a possibility that we're either misdiagnosing or labeling people with a syndrome that they actually don't have, or doesn't speak to what they're going through right now. And I put this slide up not for you to memorize, but just to show you how variable the presentation is. Speaking again to variability, not all women with PCOS are heavy. Not all women will have signs of increased hair growth or acne or male pattern baldness. Not all women will have elevated insulin levels. Not all women with PCOS will have polycystic ovaries. It's called Polycystic Ovarian Syndrome, and you don't need polycystic ovaries to have it. That's bizarre when you think about it. And, by the same token, a lot of women with polycystic ovaries don't have PCOS. So when you take all of these different factors into consideration, you can see how both patients and doctors can be very, very confused by this. So before we get into obesity, diabetes, and insulin resistance, are there any questions about the variation in presentation and how different PCOS can be from person to person?
Right now, John, I'm not seeing any questions in, but if anybody has a question, just feel free to type it and we can answer it.
Okay, great. The next section that we're going to talk about, and I would really prefer that this not turn into a lecture. We do have some information that we're going to get through, but one of the things I really enjoy about this format is the individual questions that come from people, because I think it's from each other that we really learn and grow. And people who have taken the time and the energy to come in and try and make things better by learning is a tremendous opportunity for everyone here. So please don't be bashful. Mel is very good at moderating these sorts of things.
Hey.
And sorry, go ahead.
No, I said thank you.
Nice. If you have any questions, please don't hesitate.
We actually
go ahead.
Sorry to interrupt, Ron. We actually do have a question. This question is in from Sophie.
Okay.
She was diagnosed with PCOS last winter, and her doctor put her on Metformin. Pardon me if I'm
Yeah, Metformin.
She's curious, how does a diabetic medication help with ovary production? And there's a second piece of this question. She also has heard that strict diet is key to ovulation, but she hasn't been able to find a meal plan that will help the battle. And so she's wondering if you have any suggestions.
Yeah, we're going to be getting to Metformin a little bit later. But I think one of the things that we already mentioned is that not all women who have PCOS have insulin resistance. So, I think what you need to do is take a hard look at your body type and say, do I need to lose weight? Are there improvements in my metabolism that I could make? And if you find that the insulin-resistant metabolism is something that fits with how you eat and the manner in which you gain weight, then using that concept in order to make lifestyle changes is a good starting point. Insulin resistance we're going to be getting to in a few slides, but it's, it can be controlled through diet. One of the ones that a lot of my patients have had success with is something called the glycemic index diet, which is, it's not a diet per se, but it's more of a way of thinking about food, particularly in fast food North America. And it's something that a lot of people have spoken very highly of, and has worked for patients of mine with PCOS. So that would be a suggestion. Okay, but we will be getting to that a little bit more.
Wonderful.
No one likes to talk about this particular subject, but obesity is something that is affecting North Americans at a more significant rate every single year. A body mass index of 25 to 30 is defined as being slightly overweight, and you know what? Most people are going to fall into that category. Being obese is defined as having a body mass index of greater than 30. If you're described as morbidly obese, your body mass index is greater than 40, or greater than 35 if obesity is starting to cause comorbidities such as type 2 diabetes, high blood pressure, or physical ailments. And, being objective with yourself about your weight, your metabolism, and performing a body mass index is a good first step. Most people in North America could stand to lose a little bit of weight, so there's no shame in being heavier than you wish that you would be. Ultimately, if you can't come face to face with the fact that your weight or your metabolism needs improvement, then it's very difficult to make changes. In Canada, when we look back at the trends in obesity, if we look back to 1990, only 3 provinces had fewer than 10% obese people. So the proportion of obese people in most provinces was relatively small. By 94, there were 5 provinces that had obesity rates between 15 and 19%. And then in 2000, 5 of these provinces had more than 20% of their population that were defined as obese. So, and we see that year after year that the rates just go up and up and up. And at the same rate that obesity goes up, the rates of morbid obesity are going up as well. The reason that we always talk obesity when we talk PCOS is that conservatively about 50% of patients with PCOS will meet criteria for obesity. And to understand why, you need to understand this concept of insulin resistance, which I'd like to spend some time on. On the right is a picture of something that a lot of you have experienced in my office. At your first visit, I probably asked to look at the back of your neck. And you always ask me, what are you looking for? Well, here's a picture of it. This is a skin condition known as acanthosis nigricans, and it's a very common skin finding in people with insulin resistance. This is a very dramatic picture, like you can spot this from across the room. Most cases of acanthosis nigricans need to be inspected a little bit more closely to be identified visually. The reason I do that in the office is that blood measurement of fasting insulin levels is not very sensitive for insulin resistance. So I do an examination of the fat around the belly, skin findings like acanthosis, and I talk to you about your family history, because invariably somebody will have a first-degree family member who's either pre-diabetic or has type 2 diabetes. And using those criteria, we're able to diagnose most cases of insulin resistance without doing blood work. Insulin resistance refers to essentially a decreased sensitivity of cells in your body to the action of insulin. And insulin is very important for homeostasis of your metabolism, and it's not like you can go without it. So if your body becomes insensitive to it, you make more to do the same job. And that's a very important concept. So most of us recognize insulin as an important building block in the metabolism of sugars. Insulin also has two other important actions that are very central to the diagnosis of PCOS. Most people don't know this, but insulin is a very potent growth hormone. And when I talk to patients about their metabolism, time and time again, they come back with a history of, you know, I eat the same thing as my neighbor and my girlfriend, but they don't gain weight at all. I gain weight very rapidly, and despite the fact that I hit the gym 3 times a week, I have a hard time losing it off. And that to me is, you know, immediately I key in on this as a patient with insulin resistance. That's kind of the classic metabolism where most patients with insulin resistance are not overeaters, but their metabolism is working against them and they're constantly in storage mode because of the effect of insulin. At the level of the ovary, insulin also decreases the activity of something called sex hormone binding globulin. And I don't want to get too technical here, but SHBG is a substance that binds sex steroid hormones when they're not needed to be in use. So when SHBG is inactive, you find that you have a lot of sex steroid hormones running free, essentially. When they're not bound, they're free. And that's why people with PCOS have high levels of circulating testosterone, high levels of circulating LH, and high levels of estradiol. These hormones are not necessarily overproduced as much as they're undercontrolled. When insulin is regulated, you find that testosterone, LH, estradiol come back into more normal ranges. The other thing that needs to be discussed is the relationship of insulin resistance to type 2 diabetes. Essentially, the end stage of insulin resistance is type 2 diabetes, and it represents 90% of the cases of diabetes in North America. If you want to think of type 2 diabetes as the end stage, the early stage is certain forms of PCOS. People who have obesity and polycystic ovarian syndrome are at extremely high risk of developing type 2 diabetes in life. And there's no better time than your mid-30s, late 30s, when you're young, conscious, building a family, to focus on your metabolism and focus on the lifestyle changes that can prevent the onset of type 2 diabetes 20 years later. The diabetes epidemic is very highly related to insulin resistance. From the decade from 99 to 2009, the prevalence of diabetes among Canadians increased by 70%, and the greatest increase was seen in the 35 to 39 and 40 to 40 year age groups. Well, as we know, and we spoke about this at our last webinar, these are the groups that are suddenly having pregnancies more and more often. We're seeing the age of maternal birth go up and up and up in Canada. So as that population group becomes at risk for diabetes, they're also having children at the same time. So these two phenomena dovetail very quickly. Insulin resistance is pretty common in the general population, but it's twice as common in both obese and non-obese PCOS patients. And there's a very strong genetic disposition. So if you don't know much about your family history, it might be time to start asking.
Now,
Okay.
I have a few questions here for you, John.
I bet you do.
We do. I have a question here from Kathy. She's wondering if you can get a diagnosis of PCOS just because you have long cycles, and she puts 40 days plus, then with no U/S, I'm sure you know and she knows.
No ultrasound, yeah.
There you go, evidence. No hair
Yeah.
growth / acne, etc. So that's her question.
Yeah, you could, again, you know, if you stretch, you can make a diagnosis of PCOS. I think the answer there is what are you not diagnosing? So if you have a thin patient who's not getting her periods, there are some very serious reasons why she might not be getting her period. The common one that we have to make a distinction from is something called hypothalamic dysfunction. And that's a situation where the circuit between the brain and the ovaries is not communicating well. And there is nothing hormonally wrong about the activity of the ovary. It's just that the hormonal signal that is made by the hypothalamus is not reaching the ovary in its usual fashion. It's seen very often in thin women, often women who are very athletic or who exercise very rigorously, and is treated very, very differently than polycystic ovarian syndrome. So in the setting where you don't have polycystic ovaries and you don't have the classic features of PCOS, definitely ruling out hypothalamic dysfunction would be step number one.
Wonderful. And I also have another question here from Beth. Beth is wondering if heightened androgen levels would be of concern for other long-term health-related issues. And I think this is related to the previous section.
Yeah, we find that insulin resistance and elevated androgen levels really mirror each other very closely. Insulin resistance is the greatest risk factor in terms of development of long-term health problems. As you know, the common androgen is testosterone, and if you want to find somebody who is full of testosterone, well, that would be a man. Men typically have more long-term health risks than women. Women tend to carry more cancer risks on the whole, but in terms of longevity, cardiac risk, risks of blood pressure, men run a higher risk lifetime than women do. So any hormone that is making you more like a man than it is like a woman portends to risk as well. But the major risk factor and the modifiable risk factor are your insulin levels.
Wonderful, thanks. And I think that's actually all the questions that we have right now.
Okay, and yeah, and it's just with every section we'll stop because if you're like me, you can't keep a thought in your head for more than 3 seconds. So I kind of need to blurt out my questions when they come to me. But at the end, if people are wanting to revisit any section, I'm totally cool with that.
And actually,
okay.
Sorry to interrupt again. I actually do have a few more questions here.
Okay.
One's from Melanie here, and she's wondering, is it possible that PCOS causes weight gain and that hyperinsulin causes weight gain? Or is it more likely that PCOS and hyperinsulin are a result of being overweight? And she puts in brackets here, in women who are overweight with hyperinsulin. Is it is it chicken or egg? Kind of what came first?
Yeah, the chicken and the egg concept comes up quite a bit. If you look at the action of insulin as a growth hormone, when the insulin levels are elevated, you gain weight very, very easily. One of the issues with obesity and PCOS is that adipose tissue or fat tissue is a wonderful opportunity for metabolism of steroid hormones. So within adipose tissue or fat tissue, you can get the conversion of estrogen to testosterone, testosterone to estrogen, and vice versa. So as you become heavier, the hormonal imbalance tends to become worse. And similarly, as your insulin levels increase, you tend to become heavier. So it's kind of like two vicious cycles swirling around one another. It's it seems daunting at times because it seems like you can't beat this thing. But realistically, it does get back to controlling the things that you can control, and lifestyle, exercise, and particularly aiming for a reduction in insulin levels is the best starting point.
Wonderful. I actually have two more questions here, John, for you.
Yep.
I have a question from Elizabeth. She was diagnosed with PCOS over 6 years ago and spent 4 years trying to conceive. She's wondering, after this length of time, would you start thinking that there might be something else going on other than PCOS?
Yeah, the two things that need to be ruled out in people who have PCOS are other signs of hyperandrogenism. The the two classic that are talked about are Cushing syndrome and congenital adrenal hyperplasia. Typically, if someone has classic signs of PCOS, that's something that, because it's just a common diagnosis, it fits most cases, but congenital adrenal hyperplasia and Cushing syndrome are two that should be ruled out.
Okay, wonderful. Um, I have a question here from Tanya, and she says, you might have said it, but can you have insulin resistance without PCOS?
Oh yeah, absolutely. I mean, if insulin resistance is very commonly found in males, right? There's a huge segment of the population who has type 2 diabetes, and type 2 diabetes is essentially an insulin-resistant phenomenon. There are some naturally occurring insulin-resistant states, like pregnancy, as an example, is naturally insulin-resistant. Gestational diabetes, which is a variant of insulin resistance, is found in pregnancy. So it's not unique to PCOS, but patients with PCOS have a significant increase in the incidence of insulin resistance.
Wonderful. And we just had another question creep in here. This is from Beth. And Beth is wondering, how does blood work show PCOS? She also says, was that greater to testosterone?
In terms of blood work, what we typically see is that the LH levels tend to be higher than normal. So luteinizing hormone is usually measured in balance to follicle stimulating hormone, or FSH. In a normally cycling woman, FSH is usually present at about a 2-to-1 ratio. In PCOS, the ratio of LH tends to be higher. You also tend to see elevation in, the test is available, circulating androgens like testosterone, DHEA, and androstenedione. We tend to measure DHEA more to rule out, adrenal sources of hyperandrogenism, because most DHEA is made by the adrenal glands. So it's not really an ovarian measurement as much as it is ruling out an adrenal source. The other thing that we've been doing more and more is AMH testing, which is a marker of ovarian function. And we use it to document decreased ovarian reserve in older women, but we've also found that the levels are quite high in patients with PCOS. So, we'll find some sky-high values in PCO patients where their AMHs will be getting up into the hundreds sometimes, which is, for AMH, is an astronomically high value.
Wonderful. Thanks everybody for all the fantastic questions. That's all I have for now, John. But any other questions, just type them. We'll answer them for you.
Okay, so we're going to talk about management, and I'm going to keep my favorite option for last, because I want to spend the most time talking about it. Lifestyle is obviously, it needs to be one of the first parts of the discussion. There are many, many studies that show that people who are overweight or obese who are trying to become pregnant improve their chances for successful pregnancy when they lose weight. And it's hard. I mean, we've already described a situation where, your metabolism is really working against you, and you have a growth hormone circulating through your system that is predisposing you to gain weight. And most people have tried some form of diet and exercise. It's, it is a challenge, and definitely the cards seem stacked against you sometimes. But if you devote yourself and you do the work and you lose weight slowly, like over the course of a year, one of my favorite situations is when patients win that battle and they come in and they've lost 50 to 100 pounds sometimes. And we see their results improve every time. So it's very, very hard work, but it's worth it. The major defect in PCOS tends to be ovulation. The two agents that we use other than metformin are clomiphene and letrozole, and these are oral agents that don't require a lot of monitoring, so they can usually be taken at home. They have a relatively small rate of twinning. It's about 4%, 3 to 4% for Femera, and about 8% for clomiphene. And the side effects are things that, these are common fertility medications, so you have probably heard some of the side effects. They vary from person to person. It does muck with your estrogen levels, so there's a lot of emotional lability around the time that these agents are used. Often it can be a difficult few days while you're on the medication. And then when the ovaries start to ovulate, often there's some discomfort associated with that because a lot of PCOS patients are not used to ovulating regularly. On the whole, there aren't any long-term side effects. If oral agents don't work, we tend to move to injectable follicle-stimulating hormone, and that's often paired with an IUI procedure. These agents require a lot more monitoring because PCO patients can be very unpredictable when exposed to injectable FSH. So not something you can really pursue at home. We usually will have you in several times a month for monitoring to make sure that the growth isn't too rapid and to make sure that you haven't developed too many follicles. We usually exhaust oral medications before moving to injectables. A very quick mention of laparoscopic ovarian cautery. This is typically a last resort. It's really only for people who have very large ovarian volumes. How this procedure came to be is that back when there was a surgical diagnosis of PCOS, they used to cut out a wedge biopsy out of the ovary. And they found that when they biopsied large sections of polycystic ovaries, women would start to ovulate spontaneously after the surgery. And the thinking was that by decreasing the volume of the ovary, and in particular the stromal fluid that the follicles lay in, that you could reduce the metabolic buildup within the ovary. These days, this is done by a surgical procedure that kind of bores holes into the side of the ovary and allows this fluid to be released. It's very effective, but when we have non-surgical options that can achieve ovulation, we only use this in people who have exhausted other medical therapy like ovulation induction, IUI, or IVF. In rare cases, we'll use it to enhance the results for IVF, but that's something that we do really only about 2 or 3 times a year. I mention this really for interest only. This is not a standard procedure. IVF, I read somewhere on the internet a patient saying that if you have PCOS, the only way that you're going to get pregnant is through IVF. IVF can be a strong option for some people, but PCOS patients behave very differently in vitro fertilization. They tend to be what we call high responders. Because of the large number of follicles that they have, they typically stimulate very rapidly. They give us lots of eggs, but many of the eggs will be immature or sometimes atretic because they've been in the ovary for so long. So typically, even though we get a lot of eggs, we get a similar number of embryos to patients who don't have PCOS. There can be issues with hyperstimulation, issues with difficulty with freezing embryos from PCO patients. So although you'll read in chat rooms and support groups about this being the answer for PCOS patients, it's not really as easy as it sounds. On the whole, if managed properly, PCOS patients tend to be very good prognosis IVF patients. And then the last area that should have been up at the top because it is far and away the best is metformin. So metformin is an insulin sensitizing agent. As one of the callers already mentioned, it is a diabetic medication. It's used in the treatment of type 2 diabetes, and it makes your cells more sensitive to insulin so that you don't secrete as much. It is as effective as clomiphene for the purpose of promoting ovulation, and it's been shown to lower the miscarriage rate in women who have insulin resistance. It has a very low multiple pregnancy rate, and it usually causes some weight loss as well. So this is a medication that a colleague of mine in Toronto just puts everybody on. For my purposes, about 80% of my patients with PCOS will be on metformin. This is the most common drug that we prescribe in our clinic, and this is the drug that most pregnancies in our clinic are associated with. We often say we get many more pregnancies from metformin than we do from IVF. It's a very, very powerful medication. Powerful not in the sense of what it does, but just in what it can do for the PCO patient. The downside to metformin is its side effects. It can have very wild and wicked gastrointestinal side effects, causes a lot of gut rot, and it is somewhat infamous for causing diarrhea. If it is started slowly, those symptoms will go away over time, but most people, if they discontinue metformin, will do so because of the GI side effects. If not for the side effects, this would be the perfect fertility medication for PCO. And lastly, for those who don't or who cannot tolerate metformin, there are supplements of chiroinositol and N-acetylcysteine that also improve insulin sensitivity. We have limited experience with them right now. We have had some success. I am a believer in this for people who can't use metformin, but metformin at this stage is still the tried and true, and the PCOS we either use as an adjunct to metformin therapy or in people who can't use metformin. Okay, so I'm going to wrap up, and then we're going to take some questions. So just in summary, this is a common syndrome. You know people who have it. You might have it yourself. It affects your sister, your cousin, your mother. It is not necessarily abnormal. It is a variation in normally occurring hormones, and I absolutely refuse to call this a disease. There are huge variations in presentation and diagnosis, so don't let someone else's experience dictate what you're going through. The link to obesity and insulin resistance has to be talked about. No one likes to talk about their weight or their metabolism or what they need to do, but when you have PCOS, you need to start talking about metabolism and insulin resistance. And that's not just towards the goal of getting pregnant, but also towards staying healthy throughout life. There are many treatments available, and we've really just sort of scraped the surface of all of them, but I think it's fair to say that they all begin with lifestyle and metabolic changes. It's a challenge, it's hard work, but it's worth it. And finally, as with always with these webinars, we talk about some serious topics. Please don't get discouraged. Don't let a syndrome define who you are. This is just a label, and it might not have meaning for you, and you shouldn't let it rule you. And lastly, don't give up hope. This is a good prognosis syndrome. Most patients with PCOS will get pregnant. You really just need to find the right path for you. Thanks very much.
Awesome. Thanks, John. I have two questions here for you.
Sure.
Elizabeth is wondering if other options have been exhausted, is IVF after ovarian cautery something you would normally suggest to patients?
If other options have been exhausted,
Mm-hmm.
IVF after ovarian cautery. We've done that in certain circumstances. In people who have previously not responded well to IVF, if there have been a lot of immature eggs, if we see the metabolic effects of PCO affecting the IVF process. I'm just trying to think of the last couple of cases that we've done of ovarian cautery, and both of those patients have gone back to IVF. So yeah, it's classically sort of used as a method of ovulation induction. We have used it a couple of times as a pre-IVF procedure.
Wonderful. And Tanya's asking, she says, if you ovulate regularly every 14, 16 days and are on metformin for insulin resistance, will you ovulate sooner? And if you do, what happens to the maturity of the follicles?
Metformin might shorten your period a little bit, and you know if you're ovulating somewhat late, although 18 days isn't that late, you might ovulate a little bit more quickly on metformin. Typically, ovulating earlier tends to be slightly healthier because a mature follicle will be ready to ovulate in roughly 14 days. So follicles that develop more slowly are in no way superior. Not that they're inferior either, but there's no downside to ovulating sooner. So a shorter cycle tends to be a good thing.
Great question. That's it. Does anybody else have any questions? Right now, I don't have any up on the screen, but I know that I believe, John, you're kind of through your presentation. So this is that last chance to ask questions if you had anything through the presentation. So far, I'm not seeing any, John.
Okay. Well, as you know, just as with our last webinar, I did appreciate all the people who sent emails and feedback, and you know, we will try to answer all of your questions individually. I think one of the important things to emphasize here is just how varied this diagnosis is for different people. You should really get in and talk to a fertility expert if you have access to one. It's very challenging. It's not something that your family doctor or even your general gynecologist might be up to date with. The information regarding it is constantly changing, and is something that we feel like we're getting better at with each passing year. So if you are struggling with it, by all means get some help.
I actually have two more questions here, John.
Sure.
We have one from Whitney. She's saying that a close relative of hers was on metformin and had really severe GI side effects for about 5 years while on it. She's wondering how long is a PCOS typically on metformin for fertility treatment?
Metformin therapy is usually carried out up until 12 weeks of pregnancy and then discontinued. Because it has a favorable effect on miscarriage rates, we continue it throughout the first trimester. So it's not something that someone needs to be on lifelong, but during the duration of your fertility therapy, you're going to be on it continuously.
Great question. And Melanie here, she's wondering how long it takes for metformin to show some results.
Typically about 6 weeks or so. We like to start it really slow. What I do with people is start them off on one dose once a day for about 2 weeks, and then up it to twice a day for about 2 weeks, and then up it to 3 times a day about the 6-week mark. And I usually review with them at the 6-week mark, and I find at that point a large proportion of people will already be ovulating or will ovulate within the next month. You might be able to achieve a more rapid response by starting it more quickly, but we generally don't recommend that due to the stomach side effects.
Perfect. That seems to be all the questions I've got right now here, John.
Okay. All right. Well, thank you so much for attending, everybody. I really appreciate it. Again, if you have any questions individually and you want to email them to me, I'd be happy to answer them when I have time. And thanks so much to Melissa McInerney for being our host again. Couldn't have done this without her. And I appreciate everyone who came out.
Thank you, everybody. Have a really fantastic evening.
Okay. Take care, everyone.